When assessing a patient first, we must introduce ourselves and explain to the patient what we will be doing and the goals of which we wish to obtain, thus building a rapport with your patient. Hello, Miss Dye. My name is Sarah. I will be the nurse taking care of you today. Can you tell me why you were here?
I've had diarrhea for the last year on and off.
Okay.
Constantly.
I will be obtaining a health history and then doing an assessment on your abdomen. The goals of this is to help you get answers about what is going on with your diarrhea. If you have any questions at any time, please feel free to stop me and clarify.
All right.
When conducting a gastrointestinal assessment on your patient, it is important to obtain a thorough history of abdominal and gastrointestinal complaints. You will need to obtain information about any experience, signs, or symptoms of gastrointestinal disease or disorders. Gastrointestinal disease usually manifests as the presence of one or more of the following: change in appetite, weight gain or weight loss, dysphagia, intolerance to certain foods, nausea and vomiting, change in bowel habits, and abdominal pain. First, ask your patient if they've had any changes in their appetite. Have you had any changes in your appetite?
No.
If they have, ask them about the nature of the change. Loss of appetite or anorexia occurs with gastrointestinal disease, side effects of medications, pregnancy, or with other psychological disorders. Next, ask your patient if they had any changes in their weight. Have you had any changes in your weight lately?
I have, only just because I just recently gave birth a couple months ago.
Okay. If they have, investigate how much weight they have lost or gained and in what kind of a time period. You will also want to know if the weight loss was intentional due to dieting or, as with her, pregnancy. Next, ask your patient if they've had any difficulty swallowing. Have you had any difficulty swallowing?
No.
Okay. And then, if so, when was it first noticed? Often difficulty swallowing may point to a disorder of the throat or esophagus. Ask your patient next if they've had any aversions or intolerances to eating specific foods, and if so, which ones?
No, nothing.
Ask about symptoms they experience when eating these foods. Also about the frequency of antacid use for indigestion. Next, ask your patient about nausea and vomiting. Have you had any nausea and vomiting lately?
No.
Nausea and vomiting are side effects of many medications, a manifestation of many diseases that occur frequently during pregnancy. Ask your patient about the frequency of these symptoms. If vomiting is present, you will want to ask them about the amount, frequency, color, and odor of the vomit. And if there is any blood in the vomit, or if a vomit appears to be like coffee grounds. Hematoemesis, or blood in the vomit, is a common symptom of gastric or duodenal ulcers and may also indicate esophageal varices. Coffee ground emesis indicates an old gastrointestinal bleed. The old, partially digested food appears to look like coffee grounds. Nausea and vomiting may also indicate food poisoning. Therefore, questions about types of food eaten in the past 24 hours should be asked. Have you eaten anything different in the last 24 hours that you would think that would contribute to your diarrhea?
No.
Okay. Next, ask about change in bowel habits. Have you had any difference in your bowel habits lately?
Yes, for the past year, I've had diarrhea on and off.
Okay.
Some days are good. Some days I can go to the bathroom up to 20 times a day, and it's a watery liquid.
Okay.
Stuff.
Ever notice any blood or anything in your stools?
I would say yes, but that's probably because of my hemorrhoid, because of my pregnancy that I have.
And that hemorrhoid came up after or during your pregnancy?
Correct.
Okay. No large amounts of blood or anything like that in your stool? Okay. The frequency, color, and consistency of bowel movement should be assessed. Particular emphasis should be placed on changes in bowel habits. Also assess the use of laxatives at this time. Do you use any laxatives?
I do sometimes, just because of my hemorrhoid.
Okay. Black tarry stools may indicate an upper gastrointestinal bleed or may simply be from the indigestion of iron supplements. Do you take any iron supplements?
I did, but I'm off those at the moment.
Okay. And why was you taking iron supplements?
Because of my pregnancy, giving birth, I lost a lot of blood.
Okay. Bright red blood in the stool may indicate hemorrhoids. or localized lower gastrointestinal bleeding. Current jelly stools are usually foul-smelling and resemble maroon purple-colored jelly. The presence of current jelly stools indicate a massive bleeding episode, and the patient's hemodynamic status may be assessed quickly. Next, assess your patient for any abdominal pain. Have you had any abdominal pain lately?
No.
Okay. Have your patient point to the exact spot if they are experiencing abdominal pain. Abdominal pain is usually visceral, parietal, or referred. Visceral pain is usually dull, crampy, squeezing, and may be located over an abdominal organ. Parietal pain is usually from inflammation over the peritoneum. Peritoneal inflammation usually indicates an underlying emergency and should be assessed quickly. Parietal pain is usually intense and aggravated by extension of the lower extremity, coughing, or illicit rebound tenderness. Referred pain occurs with specific gastrointestinal disorders such as appendicitis, gallbladder disease, and pancreatitis. In assessing abdominal pain and other gastrointestinal symptoms such as distension, nausea, and vomiting, ask these questions using the mnemonic P, Q, R, S, and T to evaluate their abdominal pain. Provocative or palliative. Ask what makes the pain or symptoms better or worse. Quality. Describe the pain or symptoms. Region or radiation. Where in the body does the pain or symptoms occur? Is there radiation or extension, or the pain or is symptoms to others of the abdomen? Severity. On a scale of 1 to 10, with 10 being the worst pain you have ever experienced, how bad is the pain that you are having in your abdomen? And timing. Does it occur in association with something else, such as eating, exercising, movement? After eliciting information about any experienced sign or symptom of gastrointestinal disease, ask the patient about their past abdominal or gastrointestinal history, medications, and nutritional supplements. Do you have, or have you experienced in the past, have you had any history of gastrointestinal disorders such as ulcers, gallbladder disease, hepatitis, appendicitis, hernia, past abdominal surgeries, any abdominal problems after surgery, or any abdominal x-rays or tests and their results?
The only thing I've had is a colonoscopy.
Okay.
That was back last year.
Okay.
And then it showed some type of
Gastritis?
Yes, that's correct.
Okay. Did they put you on any medications for that?
I don't believe so.
Okay. All right. Good. What medicines are you taking currently?
Just birth control and the stool softener.
Okay. And do you use the stool softener every day?
I've started to, just because my hemorrhoid came back. It's hurting a little bit, so I thought that might help.
So you won't have to strain as much?
Correct.
Okay. Many medications produce gastrointestinal symptoms. For example, aspirin and non-steroidal anti-inflammatory drugs may increase the likelihood of gastrointestinal bleeding. Almost every class of drugs has the potential for gastrointestinal side effects. Most of the side effects include nausea, vomiting, diarrhea, and/or constipation. You may ask about the frequency and duration of alcohol and cigarette consumption at this time. Do you smoke?
No.
Do you drink alcohol?
Occasionally.
Okay. Alcohol can cause liver cirrhosis and esophageal varices. Cigarette smoking leads to gastric reflux and gastric ulcers. Next, we'll assess her nutritional status. Nutritional status of your patient is very important. A thorough nutritional assessment will identify individuals at risk for malnutrition and provide baseline information for nutritional assessments in the future. Do you feel like that you are getting the nutrition you need? Do you eat a balanced diet every day?
Probably not every day, but I'm a new mother, so who does?
Okay. Do you eat normally on a normal day? Do you say you eat 2 meals a day, 3 meals a day, or?
It just varies, 2 to 3.
Okay. All right. But you feel like you're getting enough calories for
Correct.
yourself? Okay. Next, after obtaining a thorough history, we will move on to the physical exam of the patient, of the abdomen. And for this exam, I will have her lay down so I can examine her stomach. We will move to a place. have her raise her stomach. The first part of the physical exam is inspection. When assessing the abdomen, it is important to document where you note the physical finding. The abdomen will be divided into 4 quadrants. You've got your right upper quadrant, your left upper quadrant, your right lower quadrant, your left lower quadrant. Next, with your patient laying down, with your patient in supine position, inspect for bulges, masses, hernias, ascites, spider veins, pulsations, or movements, and the inability to lie flat. Normally, blood vessels are not evident on the abdomen. They may be present in the elderly or pregnant lying due to the loss of subcu fat in these populations. During inspection, you may also ask your patient to lift their head slightly. If you notice a protrusion around the umbilicus or any incisions, a hernia may be present. So can you raise your head slightly off the couch? And as I look, I see no hernia here in the umbilicus area. Next, we will auscultate. You should always auscultate after inspection and before percussion or palpation so that you do not produce false bowel sounds through percussion or palpation. Bowel sounds echo the underlying movements of the intestines. You normally hear high-pitched clicking and gurgling sounds every 5 to 15 seconds. It is suggested that you listen to bowel sounds for a full minute before determining if they are normal, hypoactive, or hyperactive, or absent. So next, I will listen to her bowel sounds. And I will listen for a full minute in each quadrant. And at this time, her bowel sounds appear to be normal. No hyperactive or hypoactive bowel sounds noted. Percussion is used. Next, we will do percussion, which is used to elicit tenderness or sounds that may give clues to underlying problems. When percussing directly over suspected areas of tenderness, monitor the patients for signs of discomfort. When examining the abdomen, percuss for general tympany, liver span, and splenic dullness. Tympany should be the predominant sound when percussing the abdomen. Air floats to the top of the abdomen in the supine position, and tympany reflects the drum-like sound. Dullness is usually heard over solid organs or masses such as the liver, spleen, or bladder. So to percuss, you would take your hand, say over the liver here in the right upper quadrant, take your finger and just tap firmly to see if you hear any dullness. Go over the spleen and see if you hear any dullness. Next,